You see that perfectly. Brilliant. So yes, thanks for the introduction. And I'm going to talk a bit about lifestyle interventions, weight management medications, and then the future of weight management as well. So the link between psoriasis and weight. So I'm not going to go into too much. Michael's been over this already, but I am just going to focus on kind of the definition of obesity, and this is the definition by the World Health Organization. So obesity is a chronic progressive disease, and it's characterized by excess body fat. And they define that by a body mass index of equal to or greater than 30. And I know Michael has talked a little bit about kind of a market, the way we define body weight, but generally it's by body mass index, but we know that there are issues with that. So it leads to adverse metabolic, biomechanical, and psychosocial health consequences. And just to kind of highlight that they do classify this now as a disease. Before, we always used to think of obesity as almost like a risk factor, but actually it's being now much more recognized as a kind of chronic progressive disease in its own right, where we know it's relapsing, and we know it can be complex. And anyone that's struggled with weight over their lifetime, I think would recognise that as well. So it's estimated that 29% of adults in England are living with obesity, so that's classified as a BMI over 30. And 64% of adults are estimated to be overweight, so living with a BMI over 25. And we know that managing weight can have a huge reduction in risk of diseases, specifically those linked with psoriasis, such as arthritis and other metabolic diseases. So treatments, what treatments do we actually have available in the NHS? So for a long time, our kind of mainstay treatment has been lifestyle interventions, and we have a number of lifestyle interventions that are available. So in your local area, there's likely to be a number of tier 2 lifestyle kind of intervention programs. They tend to be 12-week programs. They're not just based on kind of physical activity and dietary advice. They do think about the kind of 5 pillars of health, really looking holistically across. So thinking of things like stress, thinking of things like sleep, and really considering all of those things. Within South East London, we have a number of tier 2 programs such as Slimming World, which you may have heard of, Weight Watchers, but we also have a lot of locally, culturally tailored weight loss programs. A lot of them you can be self-referred to as well. So looking online, looking what's in your local areas, this can be really helpful. There is a national program, so an NHS digital weight management program. That does need to be referred by the GP, and it tends to be if you also have conditions such as hypertension or type 2 diabetes. And then we have our kind of tier 3. These are our structured tier 3 programs. They tend to be 1 to 2 year programs, and they are generally group based, but they don't have to be. And we find that group helps as peer support, and that can be really, really useful and beneficial. But it is a structured program, and it consists of and it's delivered by dietitians. In our tier 3 sessions delivered by dietitians, physiotherapists, psychologists, and it's overseen by medics as well. And they do offer certain programs for certain people if it would be appropriate for, such as things like total meal replacements, which are very low calorie diets, and then they manage you through that and then get you back onto a normal diet as well, because we know that's not sustainable or shouldn't be. I'm going to talk a bit about weight management medications. I'll go on to do that at later slides. And then obviously at the other end of the spectrum, we have bariatric surgery. So these are available through our tier 4 services. They're very specific in terms of their criteria. And you would be assessed by a medic, a surgeon, and an anaesthetist to see whether any of those surgeries would be appropriate for you, because actually in a number of cases, they may not be. And often people may not want those kind of surgical procedures, but those are the kind of treatments that are available to all. And I've put a big arrow across them all, really to kind of indicate that actually those lifestyle interventions are just as important through the weight management medications and also the bariatric surgery. And actually we need to do those to make those interventions safe. So it's kind of bread and butter through all of them, that actually some of those lifestyle interventions are really, really important. So dietary advice. So I'm sure everyone has seen this kind of eat well plate. You can access it through, I've put a website at the bottom there, so the Better Health Lose Weight, which has lots of information about further kind of giving information about this plate. So it's really important that we, plenty of fruit and vegetables. Within our kind of weight loss service, we do prioritize protein, and that because it often, but lean protein, so things like chicken, fish, eggs, to pulses, because often they fill you up, and send those signals, those kind of satiety, fullness signals to the brain. Carbohydrate as well, making sure we're going for whole grains, having some dairy in there. We really think about drinks and particularly sugar content in drinks, and directing people to have more kind of um, uh, um, drinks without sugar, such, and really water, and making sure that again people are drinking enough water. So we recommend kind of 2.5 litres a day, but obviously it depends on your health conditions whether they may be restricted or not. And then again, that also gives you a feeling fullness as well. And then trying to eat less of kind of ultra processed foods, high sugar foods, snacking. But we know that all of these things aren't easy, but and also kind of identifying as well those food packaging labels. So actually, there's a lot of hidden sugars, fats, things that we wouldn't necessarily think of. Um, and then physical activity. So again, I'm going to direct you to the Live Well exercise website. It's really helpful, and actually it has lots of videos on there, lots of exercises for particular groups of people. For example, if you're a wheelchair user, so there's lots of information on there that's really helpful. I think generally people kind of know that actually you should exercise for at least 100, moderate exercise for about 150 minutes a week, but really trying to think that doesn't just have to be going to the gym, sport, running. It's not that. That's kind of your more vigorous, intensive exercise, but being active is really important. And actually, one of the things we really focus in our weight management services is also minimizing sedentary time. So actually, our lifestyles are very much sitting in front of a computer. Our lifestyles have changed dramatically over the last kind of however long. So kind of being active and making sure we're having those movement breaks, etc. Improving balance is really important, and again, actually really building strength. So strength exercises are particularly really important if you're on weight management medications. And then on to weight management medications. So for a long time, we have had intensive lifestyle therapy and bariatric surgery at the other end of the scale. And for the first time in the last few years, we've actually now got some weight management medications to kind of bridge that gap between the two. With intensive lifestyle therapy, we're really looking for kind of a clinically significant weight loss of about of 5% or more. So when we say 5%, so for example, if you weigh 100 kilos, if you lose 5 kilos, that would be a 5% weight loss. Because we know that even at 5% weight loss, we're really starting to have an effect on those obesity-related health conditions. And actually, even at 3%, we start to have an effect on blood glucose, on cholesterol, on blood pressure. And then we have the kind of other end of the scale of bariatric surgery, where we're kind of seeing really around like 25% weight loss or more. But they are quite, you are undergoing a surgery. So to bridge the gap in between, we now have medications, which is really exciting. As long as they're done safely. But I'll just kind of go through the medications that we have. And I think it's exciting because for a long time we haven't had anything. We haven't had any medications. And that's because actually over the last kind of, 50 years, we have had quite a few medications come to the market and actually be taken away off the market because of reasons such as cardiac toxicity or psychological issues. So, we have had things come through and then them not necessarily been safe. Whereas the newer medications that are coming through, the GLP-1s, is exciting because actually we've used GLP-1 therapies for like over 15 years in type 2 diabetes. It's just that now the way the GLP-1s are coming through is that they're being manufactured a slightly different way. So the GLP-1 hangs around for a longer period of time, having a greater effect. And that's kind of how they've evolved. So for a long time, we've had Orlistat, actually good weight loss, available through primary care. However, is not very well tolerated because of side effects. Then back in 2020, we had Saxenda, so that is liraglutide, goes up to a 3 milligram dose. That is a daily injection. And that, again, good weight loss, around 8 to 10%. And then we've had Wegovy in 2023. So that's also known as semaglutide. Some people also know that from the type 2 diabetes preparation, which is Ozempic, but for weight loss, the drug we use is Wegovy. Um, and then we're looking at around 15% weight loss there. So really starting to have an effect on those kind of obesity related health conditions, which is great. And then last year we had Manjaro, and that is looking at around 20% weight loss. And once we're kind of looking over 15% weight losses, we're really starting to have effect on just general cardiovascular mortality, and things like heart failure. So really having an overall kind of what we call all cause mortality effect, preventing death. So weight management medications in the NHS. So the kind of criteria for use in the NHS is slightly different to the licensing of those medications, and that's because NICE assess for what we call clinical effectiveness. So it is slightly different to what you might be able to buy privately, for example. But on the NHS, and I'm just going to go through kind of the criteria. So Saxenda, to be honest, I'm not going to go through this in a lot of detail because Saxenda's kind of had some manufacturing problems for a while and now it's being discontinued, but we are starting to now get it back in another what we call kind of generic form. So that is kind of coming back, but it's a very specific criteria. So it's a BMI above 35 or more. All the BMIs, if they can be adjusted for ethnicity. So if you're of certain ethnic groups, we would reduce that criteria by 2.5. So a BMI of 35 or more with non-diabetic hypoglycemia, so pre-diabetes with a high risk of cardiovascular disease. So if you had sort of high blood pressure or hypertension, for example. And they were for a maximum of 2 years to only be used in tier 3 obesity services. Now, Wegovy then came about and it was approved by NICE for use in specialist weight management services, and not just restricted to tier 3, but to be used across tier 3 and tier 4, with a BMI above 35, with at least one weight-related comorbidity. Now, so just to clarify, when we say weight-related comorbidity, there is actually around 200 weight-related comorbidities out there. So, it's quite large. And that was for a maximum of 2 years, but again, to be used only within the specialist weight management services. And then more recently, we've had Manjaro approved. And this has been approved for use not only in specialist weight management, but in primary care as well. And it's for patients with a BMI above 35, and at least one weight-related comorbidity, and it's not restricted to the 2 years. So it's really thinking about that now. We recognise that obesity is a long-term condition. So as you can see, as the drugs have been approved, they've grown slightly wider in their approval. And what we throughout, they're always recommended as an option a long dietary advice and increased physical activity. And actually, each one of these drugs also has a stopping rule. So if you haven't lost more than 5% of your body weight within 6 months or till you're fully titrated, then we would consider stopping the medication. And the reason for that is actually in the trials, not everyone responds to these medications, and we don't really know why that is, but they don't. So for example, in the trials with semaglutide, with Wegovy, about 70% of patients achieved the 5% weight loss, so 30% didn't. With Manjaro, it was a bit higher, 85%, 15% didn't. So with Manjaro, however, there is when it was approved for use for this criteria, this essentially meant that 3.9 million people would be eligible for the drug, and that's really related to the obesity rates that we have in England. Now, this really wasn't kind of it's not affordable, there's not capacity for that, and NHS England agreed a rollout plan with NICE. And I think this makes it a bit complicated for people to understand, because there's lots of things in the media that it's just approved for a BMI above 35 with one weight-related comorbidity, and that's not actually the case in terms of the rollout plan and what your GP could provide you with. And in each area, the GP services aren't necessarily there. Not everyone has the knowledge and the ability to prescribe these is different in different areas, and that's what people are now trying to roll out, and that's what I've been involved with in South East London. So in terms of the rollout, so for qualifying, what they've done is recognise some qualifying comorbidities, recognising there are 200 weight-related comorbidities, and they've recognised those as high blood pressure, high cholesterol, cardiovascular disease, obstructive sleep apnea, and type 2 diabetes. And there are some restrictions within that as well. So with high blood pressure, you have to be treated and on medication. There's certain cardiovascular diseases, with obstructive sleep apnea, you have to be assessed by a sleep clinic and also then be treated on what we call a CPAP machine or equivalent. So it's not quite as straightforward as we would have hoped. But so in terms of rollout for year one, it's for those people with a BMI above at 40 or above, with 4 out of the 5 qualifying comorbidities. In year two, that goes to a BMI above 35, and then in year three, it goes to a BMI above 40 with 3 out of 5 qualifying comorbidities, and that really does extend actually the use quite significantly. And then after that, they want to review that rollout plan. And the reason they want to review that rollout plan is because there are lots more drugs coming to the market. And by that point, we do expect the landscape to have changed quite a lot. So how do the GLP-1 medications work? So they work by mimicking the gut hormones. So they mimic GLP-1. Mounjaro also has a dual effect, so it mimics GLP-1 and GIP, and they're hormones that are released in the gut after a meal, and they act directly on the brain to then control your appetite. So then releasing other hormones to make you feel hungry again, or the feeling of fullness, or changing your metabolic rate, etc. So that's how they work. They also help you feel fuller, so it slows the digestion through the gut, making you feel fuller and less hungry for longer. They work directly on the brain by reducing cravings, so actually just sort of reducing what we call the food noise, so the want for food, the thought for food. It actually also helps you develop healthier food habits, because there's certain foods that you often just go off altogether, or you're not able to eat because you end up having side effects, which I'll go through a bit later. And it regulates the blood glucose as well. So this is the particular action if you have diabetes, and that's why these drugs have been used in diabetes for a long time. So they increase your insulin secretion, your sensitivity, and the newer medication, the Mounjaro, also acts on glucagon and affects the secretion. So I'm just going to go through quickly that, although these drugs sound brilliant, they're not always appropriate for everybody, as with all medication is the case. So they're really not recommended if you have pancreatitis, or have you had acute pancreatitis. If you've had pancreatitis a long time in the past, we would kind of review that. If you have severe gastrointestinal disease, if you're hypersensitive, or if you have personal family history of thyroid cancer, or in those with MEN2, which again is a rare type of cancer. In terms of common side effects, so 1 in 10 people really experience these sort of side effects. So things like feeling sick, actually vomiting, diarrhea, constipation, fatigue, stomach pain, headaches, dizziness. But what we do when we start these medications is we really give you a lot of advice on how to manage some of these side effects, and it can be managed quite a lot by the way we kind of introduce the drug and ask you to change your diet, etc., etc. So and I suppose the serious side effect is acute pancreatitis, and that's what we would really kind of warn you about before starting. And that is if you have severe long-lasting stomach pain that radiates to the back. And then you may have seen that there, and we would just ask to go to A&E straight away. And you may have seen some cases of these coming through we've seen them on the BBC News, etc. So just kind of highlighting that is a risk, and it's really about making sure that you're the right person for that medication. In terms of pregnancy and contraception, not to be used during pregnancy, we do really ensure that you have adequate contraception, and that's because there are some studies showing in rats that there could be issues relating to the fetus if you do become pregnant on these medications. And it's really important because actually Mounjaro reduces the oral contraceptive pill. So if you are starting on these medications or you're on the oral contraceptive pill, then we really need to manage that. So making sure you have a different method, a barrier method, or actually changing some of your contraception, so to use a non-oral method. And if you were to become pregnant, we would recommend a washout period. If you have surgery, we would you need to inform the surgical team that you're on these medications, because they do come with risks, and other medications. So prior to starting, your medication should definitely be reviewed. If you have diabetes and you're on insulin or sulfonylurea, there's high risk of hypoglycemia, and we would definitely be reviewing those. And there are some other medications we would just review. And then actually, as you go through treatment, and if you did lose weight, we actually review this really regularly as well, because a lot of medications are weight based or are affected by weight. And the one that we see particularly, and that was shown in the trials, is actually blood pressure medication, because as you lose the weight as well, your blood pressure reduces, because weight has effect on blood pressure, and then you may need some medications reviewed. So we know that about 1.6 million people are actually accessing these medications privately. The private market for these medications is huge, and probably much bigger than the NHS prescribing of them, because it takes time to set up services, etc. But we know people are taking them. I have people that come into my weight management service who are already on them. They're already taking them, and what we really ask is just that we ask that people, if they come to appointments or they're seeing a clinician or doctor, that they do tell us what they're taking privately. And that's really to ensure that we just have a full medication history, and that actually you receive the appropriate care. And if you're coming in with a condition, then actually, is that related to any of your medication that you've started? If you do obtain it privately, then from a non-NHS prescriber, please ensure that it's from an authorised source. We have had lots and lots of things in the news around fake medication and admissions to hospital. We don't know what are in those medications. I know that there was recently a BBC News article where they actually seized, there was their biggest seizing of fake medications for GLP-1s. And ensure that, if you are seeing an online doctor service, that it's registered with the CQC or the General Medical Council, and any online pharmacies should be registered with the GPHC. So that's a way you can kind of check if they are okay. We do hear reports of people buying them from the gym, or certain like beauty salons, and actually that they are a prescribable medication. They shouldn't be available in that way. And it is the private provider's responsibility to ensure that that medication is appropriate for the person that is buying that medication. They do need to know their full medication their full history, and then assess whether that is appropriate, because it's not they're not appropriate for everybody. And then we always say it is a black triangle drug, which means it's a new drug, which means that we would report any side effects that happen with that medication for a certain period of time. And if that happens and you are taking things privately and you have a side effect, or you bought a fake medication, you can report that yourself on the yellow card system. And I've just put a link in there, and a person can do that, or if you report it to a healthcare professional, they can also do that for you. And I've just put in a little website there about fake meds, which gives some ideas around how you can assess as well. And then what's next? So it's really exciting in obesity medications. There are around 190 drugs in development. There are around 60 companies. It's all very exciting, the most we've ever seen. So I think the landscape will change quite dramatically. But you never know with these whether they go through the trials, or whether they come to market or not. So yeah, very exciting. And a lot of these are injections at the moment, and there are some kind of tablets and other kind of sort of intranasal sprays and all sorts of things that are kind of being looked at. So it's all very exciting.